All right. Well, thank you everybody for joining us today for the Ultrasound Grand Rounds this week. Pretty excited as we continue moving forward throughout this year. We got a couple interesting topics coming up in the next couple of weeks that I'm really hoping that you guys can make it for. But today we're going to dive in a little bit to the abdomen. So we've been doing a little bit of stuff with cardioresuscitative ultrasound already this year, and we're going to shift gears a little bit for at least this talk and talk about the abdomen. And as I was looking through the archives of what I wanted to present today, the lecture that kind of popped out at me is a bladder ultrasound lecture. And I know it sounds terribly exciting to talk about the bladder, but there's actually some interesting things that we should probably talk about, some basics we should talk about, and some pitfalls that we've run into over the course of our practice here that may be helpful as you kind of assess the bladder moving forward for your patients. And when we do our QI, this is definitely a frequent study that's done, based on the numbers that a lot of our faculty do, because it's easy. It's some pretty immediate and actionable intelligence or information. And so I think this will be helpful. I think it'll be an interesting change of gears and topic to talk about today. So without further delay, let's just dive right on into the bladder and talk a little bit about bladder assessment and how we can kind of use this in our practice, right? So that's gonna be the topic of today's conversation. And let me find my keyboard here. All right. And so the objectives that we want to go through is really a number of things, right? We want to discuss a little bit about bladder ultrasound, right? And so kind of what is it? How do we do it, right? Transducer positioning, things like that. The other thing we want to talk about is a little bit about the normal bladder anatomy, right? Because how do you know abnormals if you aren't really well versed with normal, right? And then we're going to take that and talk about how do we scan the bladder, right? What are we looking for? What are measurements we're going to do? And wrap it up with a few pitfalls as we scan bladders and just try to decide, are we doing this appropriate and getting the right answers for our patients, right? So with that said, let's dive right on in. What are we looking for, right? And if we think about bladder ultrasound, there's just kind of a couple things that we want to worry about as we're looking at bladder ultrasound. And that is, we have patients with decreased urination, right? So they're not going as much. Why is that, right? Is there some form of obstruction to their outlet, or are they just not making enough, right? And I guess you could throw in that third category if it's going somewhere else, but that usually takes us down a whole different rabbit trail of, why is there a bladder perf? So we're going to kind of leave that one alone. But is there nothing that's being produced and therefore filling the bladder, or are we not getting anything out because there's really it's being blocked up, from coming out, some form of obstruction, right? And the second thing that we're looking for with bladder ultrasound is, okay, so fine, we tried to fix the problem. We put a Foley in, right? We put this catheter in and nothing's coming out. So that loops us back into the original question. Is there something preventing the Foley from draining, right? Or is there just nothing for the Foley to drain, right? And so as we kind of whet our appetite a little bit, that's a really horrible pun, but we're going to let it hang because that was, it was kind of good. As we kind of look at bladders, right? These two patients are very different patients, right? The ultimate clinical presentation may be the same, right? You may say, I have no urine output or very little urine output, and that's very concerning for me or for the patient. But what's causing that are two very different things. So in the top left corner there, you see basically a large full bladder, right? And so if you have no, urinary production, you're probably not getting it out, right? Versus the bottom one, where you can see a Foley balloon inside a collapsed bladder around it. And so if you're not getting urinary output with that image, well, maybe it's just the fact that you're not producing it, right? And you got to look a little bit upstream at the kidney and see what's going on with the kidney to see if that's where your problem is in terms of getting urine to the bladder to then drain, right? So two very different patients that will hopefully kind of set the stage for the rest of our conversation, right? So as we get started, let's chat a little bit about bladder anatomy, or at least normal bladder anatomy, right? And as you can tell, it's a water balloon. That's it, right? It's a balloon. Now, I basically offended every single urologist and nephrologist out there who's watching this. But essentially what it is a collection receptacle for urine, right? It holds it. There's some musculature that prevents us from basically just wetting our pants all the time in kind of these socially inconvenient times, so that when it's convenient for us, right, when it's socially acceptable, we can go and eliminate kind of the urine that collects, right? And that's essentially what the bladder is. And so it's basically, from an anatomical perspective, it's a cone-shaped structure that sits in the pelvis, right? Its inlet is kind of in the posterior aspect of the the top of the trigone, right? We have the two inlets from the ureters coming in, and the outlet is at the bottom of the trigone, kind of where that urethral outlet is. And then the rest was just kind of this muscular wall with a sphincter at the bottom. Okay. And just for full credit, this image here, and some of the images that we see in the coming up in the rest of the production will be from the Complete Anatomy app, right? And it's a great app if you haven't downloaded it on your phone, your iPad, your computer, whatever device you have. I highly recommend it because it's a great way of kind of taking anatomy and peeling layers off and kind of spinning it from a three-dimensional perspective. And so that's where this image is coming from for this. All right. So that's kind of anatomically what it looks like. Sonographically, it's really going to look about the same as we'd expect it to look based on our anatomical understanding. It's going to be a fluid-filled structure. And remember, kind of from our physics conversations before, fluid, right? Just simple fluid is going to be anechoic, right? It's going to have basically, there's nothing inside the fluid to reflect the echoes. And so it's going to be black, right? It's going to be that black hole that we see on the ultrasound. Compared that with echogenic fluid, like, purulent material, that's going to have some things that it's going to reflect those sound waves. And so that may not be anechoic, but for urinary fluid, right? Urine, right? It's going to be anechoic. And so the bladder is going to be this black hole, right? And it will sonographically appear in our transverse orientation, kind of that boxy orientation or boxy shape. If you can see on the left-hand side of that screen there, it's a box with rounded edges essentially. And in the sagittal orientation or the vertical orientation, it's going to have kind of that cone-shaped appearance. So you can kind of almost imagine that triangular appearance in the sagittal orientation of that bladder. And one interesting thing, and just kind of as an aside to note, is because there is fluid in that bladder, because the bladder is full of things that don't reflect the sound waves, and by proxy, like the sound then travels easily through that bladder, you're going to have something called posterior acoustic enhancement deep to that bladder. So if you look in the far field deep to those bladders, you're going to notice that the material, that echogenic material, is a lot brighter just underneath the bladder than it would be off to the sides. And that's really because when you pass sound through a fluid-filled structure, there's no attenuation to that sound, right? During that fluid-filled structure, compared with the surrounding things that you're scanning where there is attenuation. And so by the time you get to that posterior wall of the bladder, right, the deep far field wall of the bladder, the sound intensity of the intensity of the sound that went through the bladder is going to be a lot more. There's nothing attenuated or dampening that than the stuff that's surrounding it. There's going to be dampening of the sound surrounding the bladder. And so you'll have that brighter far field beneath the bladder than you will around it. That's posterior acoustic enhancement. So some of the sonographic anatomy features and a little free physics tidbit in there just kind of help identify the bladder, right? But again, it is going to be a thin-walled structure. Normally, you won't really see the wall all that well, right? And normally, if the patient's able to void pretty routinely and without difficulty, it's going to have a small volume. Now, if they've been holding it for a while, they may be a lot larger. And I've often been curious, never actually done this study officially, to say, okay, at what point do you feel like you got the urge to go? Like, you say, okay, I feel the urge. I'm going to scan and see how many cc's are in there. And my general suspicion is that number is going to be slightly variable between person and person. I think it might be an interesting, just at least for academic understanding, study to do. But at some point you'll have some fluid in there and it'll be distended if you haven't gone recently. But normally, if you've been able to go, been able to completely void, you should have a post-void residual under 100 milliliters in that bladder, right? And again, we talked about how it's anechoic and it's got some posterior acoustic enhancement. So those are the normal sonographic findings of a bladder. The other thing to kind of throw in there is when you put some color on that, you can see that there are jets, right? You can see this plume of Doppler fluid or Doppler jet as that fluid is being expelled out of the ureter and into the bladder, right? As you can see that that light up. And so here's a still example, but it's quite impressive in video feeds when you can see kind of those cross jets. And depending on the hydration status and how quickly the kidney is making urine will depend on the frequency with which you see them. And it may be that you don't see them for a couple of minutes, but it's something that you can see that will also help identify the landmarks of where your ureters join into the bladder, right? But we'd kind of be remiss to talk about the bladder without really talking about what's surrounding the bladder, right? Or if there's anything, some anatomical structures or landmarks that might help us identify the bladder. And so the major landmark that that we want to identify, the one that we want to see, is the pubic symphysis, right? Because the bladder generally always lives adjacent to the pubic symphysis. And you can see in this image here, again from Complete Anatomy, that the bladder sits right beneath or right behind kind of that front part of the pubic rim in that pubic symphysis. And so if we look sonographically, this is the transverse orientation. And I know you don't see a lot there, but if you see those kind of two horizontal bright echogenic lines separated by a small, hypoechoic gap right in the middle, that gap, right, that's the pubic symphysis, right? And so one thing that I like to do to help identify where this bladder is put my probe down, transverse or sagittal, right? I'll show you the sagittal in just a sec, but since we're on this image, put it down in transverse, put that probe on the pubic symphysis, right? You can feel that little hump as you go up onto the pubic symphysis in that firm spot, where that pubic symphysis is, and identify that, right? I describe it as a T, right? I'm going to cut back here just to say, so you have your pubic symphysis, the different bones, and they come together, right? And just like this, and the symphysis is right in the middle. So to me, it looks like a T, the top of the T, the bottom of the T, right here, just like that. And so that, cut you back there. Good. That is kind of the anatomy that I'm looking for, or that anatomical landmark, that little hypoechoic spot in between the rami of the pubis bone there, indicating that I'm on the bone. And then all I have to do is just move my probe a little bit anterior or north or cephalad, and you'll fall right into where the bladder is at, right? And just to illustrate this in sagittal orientation, right, here you can see that little knuckle of that little hump, kind of, you see the peritoneal stripe coming down from the left, just horizontal to the the plane of the probe, right? And then you'll see a little hump kind of about 2/3 way across the screen. That's the pubic symphysis. And there's a deep, dark shadow beneath it. And right above that, you can see this anechoic fluid. And that is going to be the bladder, right? So you find that pubic symphysis, you put your probe on the pubic symphysis and look right above that, and your bladder will sit right there. And it's really a helpful way to understand the anatomy, and to really identify where you're at, and to not, fall prey to some of the pitfalls that we'll talk about later, right? Now, bladders come in two varieties, right? And maybe not so much the bladder, but the surrounding structures, right? They come in two varieties. You'll have the male anatomy and the female anatomy, right? And so there'll be some surrounding things that we'll want to look for and want to identify to help us really identify the bladder and some of these potential pitfalls, right? So from the male standpoint, we basically have a bladder and a prostate, that kind of surrounds that urethral outlet, right? And then posterior and inferior to the bladder is the seminal vesicles, right? And you can see that on our ultrasound here. So in the in this anatomy image here, we see the bladder, right? And you can see those seminal vesicles kind of laying on either side of the bladder, and then that donut-like prostate kind of surrounding the urethral outlet here. And on the sonographic standpoint, here's a transverse-oriented ultrasound. You can see the anechoic fluid collection that is the bladder, right? And then you see this bright, or this dark, or decently anechoic stripe just distal, or not distal, just deep to the bladder, and that is the seminal vesicles, right? And it's a great example of something that you can look for. That's a normal landmark or normal anatomy that you'll see on these patients. And interestingly, and I'll say this right now, because this can serve as a pitfall, particularly of doing the FAST exam. When you're looking at the bladder in transverse, and you see this stripe of fluid just deep to the bladder, that is in all likelihood the seminal vesicles, and not the free fluid that you may want to call as a positive FAST. And so be very careful when you're looking at your FAST exam to not overcall this as a positive, and not recognize that it's normal, right? Now, moving on to the prostate, right? This is another thing that you'll see that's surrounding the bladder. And in this situation, you can see the sagittally oriented bladder, right? The anechoic fluid-filled collection. And just to the right-hand side of that on the screen, you can see this echogenic ball that's kind of protruding into the bladder, right? And this is the prostate, right? And as men get older, this can get large, and you can see this protrude further into the bladder. But this is definitely something that's a normal anatomic landmark that you will see in the male bladder, and can certainly be a cause for a patient's urinary retention kind of moving down the road, right? Now, changing gears a little bit, obviously, you have the male, we talk about the male side, but there's also the female side, right? And so surrounding the bladder on from the female perspective is going to be, the big structure is the uterus, right? And so the bladder is sandwiched between the uterus and the pubic symphysis in patients ordinarily. And so if we switch to the sonographic view, I don't really see the pubic symphysis that well in this image. It's kind of cut off. It would be on the right-hand side of the screen. And you can definitely see the bladder on the right-hand side of the sector there. And just to the middle or to the left of that is going to be the uterus, right? And you see, obviously, there's a gestational sac in this one. So this is an example from a pregnant patient, but it's what you're going to see. You'll see that pubic symphysis followed by the bladder as you kind of go deep, and then the uterus just deep to that, for the female anatomy, right? So that's basic anatomy, right? And just a couple tips and techniques for identifying the bladder. Number one, look for a funnel-shaped thing in sagittal orientation. Look for kind of a square or boxy shaped thing in transverse orientation. But what's really, really helpful is identify the pubic symphysis, right? With your probe, you can feel that with your probe. Find that sonographically, that typical T-shaped appearance, or just that little knuckle of bone with the shadowing and sagittal orientation, and then look immediately superior to that. Just kind of fall right off onto that, just superior to that, and you'll be right in where the bladder is supposed to be, right? And you can also confirm your findings by just looking at surrounding anatomy. Look at the things that are normally supposed to be there, and positively identify normal things. So look for the bladder, look for the prostate and seminal vesicles, or in a female, look for the bladder, look for the uterus. These things will normally be there. And when you find your anatomical landmarks, that's going to help you then identify kind of what your other things that you happen to notice on your scans are, right? So switching gears, let's talk a little bit about how we evaluate this from a sonographic standpoint, right? What are we going to do when we do the ultrasound, and what are we looking for? What images do we need to get, right? So one of the goals, remember, of kind of this discussion and urinary or bladder ultrasound to begin with is to assess for bladder volume. I mean, that's why we do what we're doing. We're looking to see how big is this thing, to say, hey, do I need to intervene upon this? Do I need to help drain it, or is it draining itself, or am I not even producing enough urine, right? So that's going to be the main goal. And our technique is basically going to be, hey, we need to get a post-void residual, see how well this patient's able to void on their own and how effectively they are voiding. It's the ejection fraction of the bladder, as it were, if you want to borrow from cardiology terms. And so we want to measure this within a certain amount of time of voiding, right? Because as you know, you void, right? And then you continually produce urine. So if you void and then an hour later come back and do this study, I don't know what that means, right? You've had an hour's worth of accumulation opportunity or potential. And so it does, whatever number I have is meaningless to me, right? And I run in this routinely when I talk to residents who say, hey, let's do a post void. They have the patient go to the bathroom, and then at 45 minutes later, hey, let's go do that scan now. It's like, well, when did they go, right? Because we need them to go now, or they need to have gone within the last 10 minutes to make this a valid test, right? So assuming they've gone in the last 10 minutes, then you want to position your patient really supine, kind of as we do for all of our studies. That's really the optimal location or optimal position. It's comfortable for the patient. The bladder is easily accessible for us because it's right on the anterior portion of the belly. Again, all the ergonomics that we've talked about before, bring the bed up, to your height, or you come down to the bed height. Just make things comfortable for you, for the patient. To make Diane happy, grab the warm gel, right? We got gel warmers by all of our ultrasound machines. So grab the warm gel. The patients will appreciate that. And then we're going to measure the amount of urine that remains within the bladder, right? From a probe standpoint, grab the curvilinear probe, right? This is going to be probably the best probe for this particular study. It's a low frequency one. It's got the best penetration, even if you have some excessive tissue depth that you need to go through to get to the bladder. But it's going to be that penetration. It's going to be that broad sector width that you need. It's going to really be the best one. And use the bladder preset if you have that on your machine, right? Because that's going to really optimize then all the other settings in your machine to really help identify that bladder and get the best visualization that you can. Right. So from a machine standpoint, this is an example with one of our machines. We're going to go and we just basically go down that list. We select the transducer, we select the exam preset, and then we go to scanning. So there we select the transducer, we selected the bladder preset, and boom, we're ready to roll with that that imaging study, right? And then it's time to basically scan the bladder. And what you want to do, this is a option or the example of a sagittally oriented bladder. And you find the bladder, right? Find your pubic symphysis, go right above it, find that bladder, and scan back and forth. And what I like to do is scan the entire pelvic bowl, right? Scan all the way to the vessels, like the iliac vessels and the iliac crest on one side, and then scan all the way to the vessels and the crest on the other side. So you see the whole width of the bladder, right? And you want to stop and freeze your frame where the bladder is its largest in its sagittal orientation, right? Because you want to find kind of that maximum diameter of the bladder. Once you've done that, then it's time to go to the transverse orientation and do the exact same thing. So you put your probe down, find your bladder, right? Identify your pubic symphysis, go right above it, and scan all the way up. So all the way down, from, like go to all the way to the bottom at like the urethral meatus, right? Or not the urethral meatus, the urethral outflow of the bladder, and then scan all the way up past the dome of the bladder to get to the top, right? And see all of that and stop and freeze your study where the bladder diameters and dimensions are the biggest, right? And so essentially what you're going to do is in two-dimensional space, construct this three-dimensional model of some form of a spherical structure, right? And so this is just an image that I found of an oval-shaped spherical structure on Google, but it shows you that there's three cardinal dimensions that we're really trying to identify, right? We're trying to identify the height, the length, and the width, right, of this bladder to kind of get these three measurements. And it all goes into this formula, which there'll be a test on this in about 10 minutes, just kidding. But it goes into this formula, which actually the machine has embedded into its memory, and you can plug these different dimensions in and it'll spit out a bladder volume for you. So your volume is going to be roughly equal to the length times the width times the height times a cofactor in this situation, about 0.52. And you can get that measurement of bladder volume. And so what you'll do is you'll scan and you'll get these measurements. And the way I like to do it is I like to use the dual function of the machine because it puts both images on the screen at the same time. I don't have to flip between images and kind of mess something up, but I get both images there. So in this situation, what I did is I found, I'll replay that one real quick. I found the transverse oriented window, found the biggest one, hit the dual button, and that gave me another screen, right? Put another window on this next to it, went live. I was able to switch to sagittal orientation, scan, find the biggest measurement area that I could, and freeze on that, right? And once I've frozen that, now I have two different orthogonal views that I can measure, getting that length, height, and width measurements to then turn that into a bladder volume. So if we take that still image, so this is a different patient, obviously, but kind of same concept. We have on the left, we have the transverse oriented image, and on the right, we have the sagittal oriented image. And I can measure basically the inner wall to inner wall, right? I want to measure the amount of urine that's in there. So inner wall to inner wall in the length, the height, and the width. And get those three different measurements. It goes into the calculator. And in this situation, it spits out a bladder volume of 480 centimeters cubed or 480 milliliters, right? Now, absent any clinical information of when did the patient last urinate and kind of what's going on, the number 480 is meaningless to me because I could probably drink a ton of fluid and hold long enough to reproduce this in myself or some other normal, healthy person, presuming I'm normal and healthy, right? So what I'm more interested in is when you go, what do you have left? And this, if you have this left, and that's a problem, but if this is kind of, the max you can get, by just holding it, whatever, right? But at least it gives us a number of 480 milliliters of urine in this particular bladder, right? One important thing though, when you make the measurement is you actually have to measure the three different dimensions, right? The length, the height, and the width. So in this situation, or in this image here, we're showing that, on the left, you have your transverse oriented bladder, right? And so we're having, as we're looking at this patient, anterior is going to be in the near field, posterior is going to be in the far field, left and right is going to be, left and right on the images are actually going to be inversed because of the way radiology images are read. And on the right-hand image, right, that's the sagittal-oriented one. So that one is going to be cephalad-caudad measurement, right? So when you do this, when you have those two orthogonal windows, you want to measure with a plus sign on one of them, right, and a minus sign on the other one. And it doesn't really matter which one's which, right? It doesn't matter which one you use, but it needs to be a plus sign and a minus sign. And it's for this reason, right? The yellow line represents the depth, right? The anterior to posterior depth. The red line represents the left to right width, right? And the blue line represents the cephalad to caudad height. So we got our length, width, and height. Contrast that with if you do a plus sign and then a vertical line in one of the other ones, right? And I see this all the time when I do QA. If you do that plus sign in a horizontal line, you have the yellow line representing the anterior posterior depth on the transverse. The red line represents the left to right width, right? And then if you go to the sagittal image, you still are measuring the anterior to posterior depth, right? So we have depth, and width, but we're losing that height measurement, right? And so it gives us an inaccurate number if we use the plus sign in a horizontal or a vertical line as our measurements that we use. So remember, right? Always do the plus sign and the minus sign. And it doesn't really matter which one I use, because no matter what I choose, this yellow line should be about the same if I'm measuring in the maximal dimensions, right? In the sagittal and the transverse orientation. So again, that's a huge pitfall that I've seen a lot, right? So that begs the question then, what is urinary retention, right? And basically, if you want to define it, urinary retention is the inability to get urine out, and it's therefore retained in your bladder, right? And I've asked around a little bit, I've read around a little bit, to find what is an optimal number. And the urologists kind of basically say, well, it kind of depends on the clinical situation. But if you kind of take all the sources and put them together, I would say, and the number I generally use is urinary retention for an adult is somewhere around the neighborhood of greater than 200 milliliters of urine that's left in the bladder after a void, right? The post-void residual is greater than 200 mLs, right? If it's less than that, it's probably not urinary retention. If it's greater than that, then it probably is, right? And so that's kind of numerically what it is. But then that doesn't answer the question. We see that patient like with pelvic pain, and you throw the Foley in, they get a ton out, and all of a sudden they feel better, right? Okay, so you answered why they're in pain, but didn't really answer why they had the retention that caused them to be in pain, right? And so when we talk about urinary retention, there's a huge differential that opens up for us, and that we got to think through and potentially ask questions, as we interview our patients. That differential includes things like a neurogenic bladder, right? Some form of cauda equina syndrome, right, or cord compression syndrome, some urinary outlet obstruction, right? Maybe there's a mechanical obstruction, a medication-induced obstruction, or some form of a UTI that's causing inflammation and things are being obstructed, right? And I've definitely seen different examples of these. And like you could think about, urinary outlet obstruction. Great example of that is BPH, right? Benign prostatic hypertrophy, where it's just the prostate becomes so big that it kind of pinches off that urinary outlet, right? Mechanical obstruction, we'll show a picture of this later. Did the Foley get put in all the way, right? Or did something that we put in there block that off, right? Medications, think about like an anticholinergic toxidrome, right? So you overdosed on Benadryl or some other anticholinergic. One of the hallmarks is urinary retention, right? UTI kind of stands on its own and is self-explanatory. So that's bladder volume, kind of how it's helpful in terms of doing and identifying that size. The second thing where this becomes helpful is Foley catheter assessment, right? So we put in Foleys for various different reasons, despite infection control's best efforts to have us not do it. But there are times when it's appropriate, right? Where it's good to do that for the patient's sake. And sometimes those Foleys malfunction, right? And we down in the ED see it as, hey, my catheter hasn't drained for 3 days, what's going on? And I'm sure if we talk to our ICU folks that are here today or even watching this later, they would have examples from their own practice where a Foley malfunctioned or there was a problem with a Foley catheter in these patients, because it's not, it goes in and it always works, right? There's always malfunctions to this material. And so the ultrasound can be really helpful in identifying, okay, did my patient just become, anuric because they're just not pretty, like the kidney is shutting down, or did my Foley block something off that's preventing things from coming out? So for example, this is a patient where we can see the Foley balloon inflated inside the bladder, right? And Foley balloons, just kind of back up a little bit and talk about it, tend to be like bladders, right? They are filled with saline, right? They are anechoic, rounded structures, and you'll oftentimes see that little tip of the Foley that extends out beyond the balloon. So in this situation, you can see that rounded anechoic structure inside the bladder. And if you look to the left of the balloon, you can see that little tip of the rest of the Foley catheter. But you can see in this situation that we have a bladder that's decently decompressed around that Foley. There's not a lot of fluid inside that bladder. And so if we get no urine output, this probably isn't a problem with the Foley as much as it is the problem with the patient not producing the urine, or just us not, cataloging and collecting that urine appropriately to measure the outs for the I's and O's. So it's not a Foley problem in this situation. Contrast that with this patient, right? So this patient had no Foley output or diminished Foley output. And when we scan, we find that Foley balloon is well inflated, but it's not inside the bladder, right? You can see that large bladder in the near field, and you can see the small Foley balloon in the far field. And this one is inflated in the proximal urethra, right? And so if you deflate that, advance the balloon, then you can get this get the balloon inside the bladder, and you can see the example of that here, where now you have a Foley that's inside the bladder, right? And we can even create a third scenario, like let's say we have this patient where the Foley is definitively inside the bladder, and we have a full bladder. Well, maybe now you have a problem with your Foley itself, not just the placement, but maybe you have an obstruction inside the lumen of the catheter. So different ways that the bladder ultrasound can help you troubleshoot some of the problems that you may discover, you may find with a Foley catheter. So with that being said, let's talk through a couple pitfalls. And these are cases that we've seen down in the ED where patients have scanned a bladder and something has gone amiss in terms of the bladder scan, right? Recognizing it or doing something like that. So case number one, this is going to be a young female patient presenting, let's say, with pelvic pain, right? I think the presentation is probably less important than the sonographic image in this certain circumstance. So this is the study, or this is the image that was obtained for a transverse bladder, right? So it's kind of got that anechoic fluid collection appearance. That's contained fluid, it's not free fluid. So we got that. And then we have the sagittal oriented bladder, right? And they measured it, and it's rather large. It's 9 centimeters in length. So this patient, for all intents and purposes, presumably has urinary retention, right? However, I'm bringing it up in the pitfalls section. So the question is, what's wrong, right? What's wrong with this study, right? And so we're going to go back. Let me show this image, right? So this is one of the images that was captured in the study. And as we look at this, right, that's a very large fluid collection, right? But is that the bladder, or is it something else, right? And if I put some labels on that, we can see that maybe it's something else. This is actually a very, very large ovarian cyst. And this is why I spent a lot of time really hammering in the anatomy, right? Why you want to definitively identify not only what you believe to be the bladder, but the surrounding structures to confirm that. Not just it's a fluid collection in the pelvis, it must be the bladder. Say, okay, fine, but is it truly the case? And let me confirm that. And so here we can see, obviously, it's a sagittal oriented view of the female pelvis, right? And so the uterus is not unclear, right? We saw that in the previous image. But you can also see a very decompressed urinary bladder indicated by UB there. And if we really found that pubic symphysis, walked it right above the pubic symphysis, we would have seen the decompressed bladder and then this large fluid collection adjacent to that we would have said, you don't have 2 bladders, you must have 1 bladder. So what's this fluid collection? And then kind of decided, kind of work that up as finding that as the ovarian cyst. So be very careful, right? And so the take home points for this one is, not all things that are fluid filled in the pelvis are bladders, right? And also, and this is never 100%, right? But the geometry didn't quite fit, right? This one tended to have a little bit more rounded spherical appearance and not that very boxy and cone-shaped appearance that we'd expect to see in the transverse and the sagittal bladder, respectively, right? So when you see something that's rounded, just make sure you confirm it, right? Double check, before you immediately call the bladder. And really, again, this is going to be the case for this study as well as for the subsequent case series that we have here, is make sure you identify the surrounding anatomy and scrutinize that, because that's really going to help you identify what your primary target is, or that primary structure that we're looking for, and confirm that it is or is not what you're thinking about. All right, so this is case number 2, right? So this is going to be, I don't know, let's say a 75-year-old gentleman who comes in with inability to void, right? So here is the transverse oriented image. There's a measurement there about 5 centimeters, okay? And if we do the sagittal oriented image, there it is. Looking at about another 5 centimeters for that bladder, okay? If we do a bladder volume assessment, right? putting those together, you get about 82 cc's of fluid in that bladder. You guys happy with that? You cool with that? You good? You want to move on? All right. So the question, again, I bring this up in pitfalls, so there must be something wrong with this one. What's wrong with this study, right? And let me put some labels on this, and we'll kind of walk through this one a little bit, and it'll make more sense. What we measured, or I should say what was measured in this situation, was the prostate. Okay, now it's a very large prostate, but it was the prostate nonetheless. So here you can see in that that sagittal oriented image, the pubic symphysis. Remember, see that bright white rim of the pubic bone there in that dark shadow, right? That's the landmark that we're looking for. If you go immediately above that, right, you can see the urinary bladder, which is very much decompressed in this situation, right? Again, UB represents the bladder. You can see that the wall of the bladder decompressed, so there's not much in there. And then the prostate just deep to that, kind of where we'd expect it to be, right? Remember, the kind of inferior posterior aspect of the bladder is kind of where the urethral outlet is, and it's going to go through that prostate as it goes down south, kind of coming out to the, the external urethra, right? And so that's an example of the prostate, right? And it's, in these patients, it can be decently easily confused with the bladder, because if you just prop your probe down there and say, oh, there's an anechoic or in this situation, a very hypoechoic structure, it's easily just assumed that that's the bladder when it may not be, right? And so in this situation, again, take home points, why this isn't the bladder. Number one, just like before, it's rounded, right? It looks like a perfect sphere. There isn't that boxy or cone shape appearance. Number two, this one's echogenic, right? And I'm not saying that all bladders are anechoic, right? If you have a hematoma inside that bladder, there's certainly good reason for that to have some echogenicity to it. But a simple fluid-filled urinary bladder should be anechoic, right? And in this one, if we go back here and look at it, it is decently echogenic, right? As we kind of go back and see some of these images here, there's some echoes in there that should at least make us think twice before we immediately call the bladder. And again, right, look at the anatomy, right? If you look for the pubic symphysis, go immediately above it, you can see the decompressed bladder that's separate from the structure that we're assuming is the bladder, indicating that we're off to the wrong start to begin with, right? So that's case two. Here's case three, right? This one's a little bit more challenging. So here's a sagittal oriented image. We got two different measurements, 2 centimeters and 2 centimeters, or almost 3 centimeters each. We found the pubic symphysis. It's right above it, right? Here's the transverse oriented. It's 3 or 4 centimeters, giving us a 13 centimeter or 13 cc structure. Again, what's wrong with this image? Well, it's a little bit too high, right? So we did the right thing. We tried to do the pubic symphysis, but generally the bladder should be kind of tucked up underneath there a little bit, right? You should be visible. It may be challenging to visualize if it's that small, but it should be tucked in a little bit more. So this is some other, hypoechoic structure that's a little bit farther up in the bladder, right? So it's too high to be the bladder in this particular example, right? And I challenge you to kind of look around. I'm sure with other images that the bladder would actually be found, right? And the final case is case number 4, right? And so let's just, I don't know, we can pick any type of patient demographic. So we'll say like a 50-year-old female patient coming in with abdominal pain and vomiting, right? They say their pain's mostly in the lower abdomen. So you scan and you get this, right? So here's an 8 centimeter in transverse oriented structure. We go on the other orientation. You have sagittal orientation. There's no measurements here, but it's an anechoic structure. Whoop, there's anechoic structure. It must be the bladder. We're kind of down in the pelvis. All is good, and let's call it there, right? But we should be asking ourselves, okay, number one, it doesn't fit the shape characteristics. I mean, from this standpoint, okay, maybe it's boxy, but it's very shallow, right? It's kind of odd. It doesn't quite fit the shape that I'm expecting. This one's very rounded, not that cone-shaped appearance. But what's all that stuff in it? And again, I said that there could be echogenic stuff in the bladder. So maybe it's a hematoma, maybe it's some other thing, right? Doesn't necessarily rule it out per se, but it definitely should cause us to question. And so as we scan around, we find this, right? We find something that looks a little bit more tubular than something that's rounded or cone shaped, and there's some extra things hanging from the wall and emanating from the floor of this thing. And this is an example of basically a dilated loop of bowel, right? So this patient has a bowel obstruction. They don't have a bladder outlet obstruction, right? So why this one isn't the bladder? Well, number one, it's an echo-filled fluid structure, right? So when it's echo-filled, at least think twice. Not saying it can't be the bladder, but think twice. Number two, it's not rounded. It's a tube, right? You can follow that tube, throughout the bowel, and it's got the plicae circularis on it, right, from the bowel obstruction. So all three reasons why this one is not the bladder and should not be confused with the bladder. So again, go back to your basics of looking for the surrounding anatomy. And that brings us really up to the review. And we'll end with this one because I think this is just kind of a good way of summarizing things. The bladder scan, it seems like a simple scan. It's definitely a simple scan when you can do it well. But be very, very careful. So, evaluate the surrounding material very carefully. When you find something, make sure you see that adjacent anatomy, particularly that pubic symphysis, because that's really going to help you hone in on saying, yes, this definitively is the bladder, right? A post-void residual, at least in my books, is going to be greater than 200 mLs, right? That's what I'm using when I'm QAing different studies that we see here. And just be careful that you measure it in the three appropriate dimensions, the length, height, and width, and that you don't substitute that height dimension, for a second depth dimension or whatever configuration you have to do, that it's a plus sign and a minus sign, not a plus sign and a vertical sign. So with that being said, that's going to wrap things up for here today with the bladder scan. Hopefully this was somewhat helpful, educational, enlightening, entertaining. But are there any questions that you may have as a result of kind of this conversation or things that this may bring up?